back, let's say that's the sensory strip, and then in front it's a motor strip. And I've got the same thing on the other side of the brain here. In the middle, on either side of that third ventricle, we have the thalamus. Okay? That's going to be an important junction point for sensory nerves that are going to be going out to the sensory strip. So if I say in the back, sensory cortex. You know the other name for that gyrus?
Which one?
The sensory.
Central?
Post-central. Post-central gyrus. Okay. Sensory cortex. And then motor here. The precentral. Okay. So we have the, I'll say that's the pons. That's the medulla. And the cord is going to look kind of small. I'm going to do the cord a little bit bigger this way. Okay. And you have that little butterfly shaped gray matter in the cord. Okay. And that's going to distinguish where some of our nerve cells actually live. I think we've already talked about the cells that live in the anterior horn. Motor or sensory?
Motor.
Motor, good, good. That's where the second neuron lives, okay? And it's called the lower motor neuron. The upper motor neuron that's going to make that one fire, if that's a cell, if that's going to fire, that's up in the motor cortex. That's the first one. That's where it lives, okay? It sends an axon down through the internal capsule, down through the pons. It crosses over in the medulla to the other side. So if this, let's say this guy is facing you, the left side of the brain is going to get the right arm, right foot. So it has to cross over. It crosses over here. Okay, in the medulla. And it's called the decussation of the pyramids. That's the medical term. But it crosses over to the other side, and it's going to run down along the lateral part here in the white matter of the cord. Okay. And let's say it's going to keep running down that in the white matter. Here's the gray matter in the center of the cord. So it's a lateral tract, okay? And I'll give you the name of it here in a second. That is going to make that motor neuron fire, and it's going to come out the ventral root, okay, of the cord. There is a dorsal root back here, which has a ganglion. That's sensory. That's where the sensory cells live, in the ganglion. And then this is going to join them. This is going to form the spinal nerve. Okay, so it's going to have sensory coming back and motor going out. Say it's headed to the foot. Okay, that would be the right foot. Okay, left brain, right foot. And now, the name of that tract, okay, if we think about, just like we name muscles, origins to insertion, okay, they name the tracts in the spinal column origin and insertion. We can look at it that way. So it's cortex, it's the corticospinal tract, corticospinal, okay, lateral corticospinal tract. Central nervous system, remember, of which the spinal cord is part of, they call them tracts, not nerves. Okay? So that would be the lateral corticospinal tract. Now we have two different kinds of basic, there's more than two basic kinds of sensory pathways that you need to know. One is pain and temperature. The other one is kind of a conglomeration of fine touch, vibration sense, position sense, that sort of thing. I know where my arm is, that sort of thing. Those nerves that let me know that are in a special tract. So those nerves are going to come up. Again, the ganglion is here. Okay, they might synapse. They're going to go up on the same side then they're going to cross over in the medulla and go to the sensory cells here. Well, I made a little pathway. It's going to be hard to draw it here because it's got to go up to the thalamus, and then the thalamus is what's going to go to the cortex. Okay, remember, all the sensory stuff, sending signals, goes to the thalamus if it's going to get to the cortex. Okay, so you can, if it's starting in the spine and going to the thalamus, you name the tract.
Spinal tract, spinal
Spinothalamic tract. Spinothalamic tract. That's the main sensory tract. Okay. Well, you know, it just goes to show you I can make mistakes too. The one that's going up on the same side of the cord and then crossing over in the medulla is not the spinothalamic tract. Okay. The back part of the cord here, okay, I'm going to draw a bigger spine. Okay. Here's our little butterfly, anterior horn, posterior horn. There are some tracts back here. Okay. These are called the dorsal columns. Okay. So for fine touch, vibration, position sense, that's coming in the sensory root, and then it's heading up the dorsal columns. Okay. So it's in the back part of the spine. So I'm just going to call this the dorsal column. You'll see dorsal funiculus. Funiculus is Latin for cable. Okay, it's also called that. The dorsal column. Okay, that's for, and I'll put this here, fine touch. And I'll put position sense. Okay, dorsal column. And so that's the first sensory tract that you should be aware of. The next one is the spinothalamic tract, and that's for pain and temperature. Okay, so it's coming in, just back in the sensory root, just like the other ones are. All the sensory stuff goes in the dorsal root. But instead of going up on the same side of the cord, it's going to cross over and then go up this side. Okay, and since it's already crossed over, it goes up to the thalamus and then out to the sensory here. Okay, it doesn't have to cross in the medulla. It's already crossed over in the cord as it goes up. Okay, so your motor fibers are crossing over in the medulla. Fine touch, position sense, vibration sense, they're crossing over in the medulla. But pain and temperature, if I burn you with a hot poker, that one is already crossed over in the cord at about the level where it enters. Maybe it takes about one vertebrae length for it to cross over as it starts to go up. So, but it's now going up the same side of the cord where it's going to hit the brain, but it's got to go through the thalamus because it's sensory. Okay, and then it's going to go back out to the sensory cortex. That is the spinal thalamic tract.
So the motor touch crosses over to the medulla, and so does the fine touch. The pain is already crossed over the cord.
Right. Pain and temperature. Okay. Hot and cold sensation, that sort of thing. That crosses over in the cord and goes up on the same side. So that's.
And goes to the thalamus.
Right. Right. They all go to the thalamus.
All sensory go to the thalamus, right?
Uh-huh. Spinal thalamic tract. Okay. So that starts to get busy, but luckily there's only 3 of them that we're going to be concerned with. There's probably a dozen tracts in there because some of them are going to the cerebellum and some of them are going to other parts of other parts of the brain. But these are the 3 main ones that I want you to be just aware of. Okay? So what could I ask you about this whole system? What kind of lecture questions? This is not going to be lab. Okay, this will be lecture questions for these pathways. You remember what an afferent nerve is versus an efferent?
What afferent would affect?
Is that something about taking it away from?
Well, efferent, like efflux. That's going away, okay?
Okay.
Afferent means two, okay? And we arrange this and say that all the nerves that are going to the brain, okay, are the afferent fibers, okay? So they're going to be sensory, right? The motor fibers, their axons are coming out, they're projecting out, so they're going to be efferent. So I could ask the question something like, the sensory nerve fibers, traveling, or sensory axons traveling through the spinal cord have their nerve bodies in what structure?
Can you repeat that question?
Sensory nerves traveling through the spine have their nerve bodies in what structure?
Spinal thalamic tract?
And the little spinal column, the little dots on
The
the
dorsal root ganglia. Right. This is where the sensory nerves live. Remember, the motor live in the anterior horn of the cord.
Right.
The sensory ones live out here. Okay.
Can you repeat that question again?
Well, I can make up a bunch of different ones.
Okay.
The spinal thalamic tract is composed of efferent fibers. True or false?
False.
Okay. Everybody got that though?
Yeah.
You know why?
Because afferent is the center that goes up
Because
to the brain.
They're afferent fibers
Right.
going up to the thalamus.
Afferent go up,
To the brain.
okay,
Okay.
afferent,
Efferent, efflux, like,
Okay,
like
afferent
refuse,
goes
it
up.
means like, going away.
okay.
So that's about as simple as I can make the system. So, but if you can understand this, you'll be doing fine. So the dorsal columns, I could ask you, what are the sensations that the dorsal columns tend to carry? And I'd say pain and temperature, fine touch, and you'd have to be fine touch, okay, something like that. Okay. Motor neurons originating in the motor cortex will synapse with secondary motor neurons in the
Anterior horn?
anterior horn, dorsal column, spinal
Okay.
thalamic tract. I could just make up some words,
Okay.
But so you have to know in your head that motor is going down, crossing over the medulla. It's going to synapse with a motor neuron, the secondary neuron in the cord, in the anterior horn, okay? And then it's going to go out the ventral root of the cord, okay? The dorsal root is all sensory. They will eventually come together to form a nerve, okay? Just the simple ones are the ones, the thoracic ones, that just come out the intervertebral foramen, and that the spinal nerve just travels in that costal groove, okay, as it goes around. And then it's sending out little fingers of nerves to get sensation and to run the intercostal muscles and things like that. The motor is running them. The sensory part is sending out little fingers that are going to give you that stripe of sensation that's responsible for that one nerve, okay? Which is why we get the dermatomes, okay? Which is why you have T4-5, T10 is around the umbilicus, T12 comes around about the pubic region, okay? We already did the dermatomes, right? We didn't talk about them yet?
I think so.
Okay, well, we'll get them today. So we've been jumping around the slides a little bit. Okay. So this is basically information I want to put out there for the cord. We'll look at pictures of the cord, and you already realize, I think, that it's all covered with dura, okay? And then you have the arachnoid, and you have the pia, it's right on the cord, and you've got to get into that subarachnoid space to get cerebrospinal fluid, okay, when you're doing a spinal tap. You remember what level the cord stops?
L5?
L2?
No, it's higher.
Well, L1, L2.
Oh, L2.
Right. That's why you do spinal taps lower,
At L5.
L4 or 5.
Okay.
You're trying to miss the cord. You don't want to do it up high and hit the spinal cord. We'll look at pictures of the cord. It has a dangling spinal nerves that when the cord ends at about L2, you still have all those spinal nerves that are running down, because they're going to have to go out the lumbar, 4-5, and the sacral foramen, they're going to have to go out. So you just have this horsetail looking bundle of nerves, and that's exactly what they call it, the cauda equina, the horse's tail. Okay?
Okay.
And that'll be on one of the slides coming up. go over this. So, guess what would happen? There's a classical neurological lesion. Somebody gets shot or stabbed in the back, and it goes through half the cord and knocks out one half of the cord. Okay? What if we got stabbed at, let's say, T10 and cut out half the spinal cord at that level?
They would be paralyzed from that down.
From that area.
And paralyzed in what way?
They wouldn't be able to feel or move. If,
Motor,
Okay, we're
You're
gonna,
paralyzed on one side.
we're gonna
You'd be
get,
able to feel pain.
we're gonna get the motor.
okay.
You got it. You got it. You're gonna get the motor, say in that right leg, okay?
Okay.
You're gonna get the fine touch, position sense.
Right.
Okay, that's gone, okay? But pain and temperature is still active in that leg.
Weird.
But guess where it's gone?
where?
To the other side.
The other side. Because the pain and temperature crossed over. Now it got
Oh,
cut.
that's right.
So now your left leg has no pain and temperature sensation, but your right leg is paralyzed. Okay? So that's called a Brown-Séquard lesion, a classic neurological problem. So, okay, so I throw this out for your amusement, all right? Spinal column. Did we get this one yet? This is, I don't think this will come as any surprise to people that we have. These are the spinal nerves coming out from the central nervous system. We call this, the ones obviously coming from the neck, those are cervical spinal nerves. They will come together. You see this grouping right here? That's called the brachial plexus. There's actually nerves from different levels that are intermixing so that they're forming. You'll have sensation in the hand that comes from a couple of different levels, okay? Because these nerves are all mixing together here. I knew that was going to happen. Let's wait a second. And then, obviously, the thoracic nerves, they come out. They're a little bit more simple. They come out and go down the costa root and go around to the midline of the body in the front, ventrally. Okay. And then you have the lumbar nerves that come out. They actually kind of get together and form a plexus as well. That's what we call a nerve plexus, when different spinal nerves are coming together, and then they form, say, one larger nerve. So it's the lumbar plexus that forms the femoral nerve. Remember the one that was in the femoral triangle in the muscle models? Okay. It was vein, artery, nerve right there. Okay. That's the femoral nerve in front. I'll show you what that plexus looks like after a while here. But, and then you have the sacral plexus, where the sacral nerves get together. And they go down the back. They come out the sciatic notch in the back part of the pelvis. Okay? And then they're going to travel down the back part of the leg. The femoral nerve is mainly responsible for your quadriceps, for one thing, as well as the sensation in your thigh and the front part of your leg. So the sciatic nerve comes down and gets the gastrocnemius and the soleus and that sort of thing in the back here. So those are the nerve plexuses. We'll get to those. When we look at the level of sensation, now this is not for motor, this is for sensation. You can see it's pretty simple from the thoracic. T1 starts about your clavicle, and T12 ends right about the pubic bone. Okay? T10 is about belly button level, and T4-5 is nipple level. Okay? So you can literally, if somebody has a spinal injury, you can literally just take a pin and test them and go down, and you can almost draw a line right around their body where their sensation stops. Okay? So you can tell the level of the injury. If it's not obvious, if they've been stabbed in the back, okay, so they've got some sort of tumor on the spine and they're paralyzed from there down, you can actually just do the sensory testing and you can guess what level where that thing is. So that's one thing that's nice about neurology. It's all wiring. If you know the wiring, you can kind of predict things and where problems are and that sort of thing. So, but if you just remember that the cervical gets just about everything above the clavicle and most of the arms. You get a little bit of T1 on the inside of the arm there. Okay? And it's easier to visualize this if you think about a four-legged animal, which we used to be. Okay? So the cervical nerves are going to get everything down to about the clavicle, so they're going to get the front part of the arm here. Back inside of the arm is where T1 starts, and then it starts walking down the body until you get to about the pubic bone, and then it's lumbar. And that's why the lumbar plexus gets the front and sides of the legs, and then as you go back to the sacral, you start to get the bottom and the back of the extremities. So that's why you see these numbers like this. Like when you turn around, it's sacral in the back. Sensory is in the back is sacral, in the front it's lumbar. Okay? So femoral nerve and sciatic nerve, getting all this. So, and one of the things you do with spinal injury is rectal exams to check the muscle tone of the rectum. Okay? Because if that's looser than normal, you've got sacral injury. Okay? So, easy question. I might just ask you, sensation to the back of the head is cervical, thoracic, lumbar plexus, you know, that sort of thing. It's easy, back of the head. What gets the front of the head? Remember?
Trigeminal?
Trigeminal, right. That's one of the cranial nerves. That's why the cervical nerves here get the back of the head, but not the front. Okay? So trigeminal is sensory to the face. This is just a simple picture of the cord. Remember, they're calling this the posterior funiculus. If you call it the posterior columns or dorsal columns, okay, is fine with me. Okay. Here's your butterfly. Here's your anterior horn. Okay. This would be where the lateral tracts are running. Okay. There is some motor and sensory in the anterior tracts here, but it's a small percentage. Again, if this is motor, the motor roots are going to be coming out here, okay, in the ventral root. Remember, stomach side is ventral. The dorsal root is sensory. The sensory nerves, bodies are in this little ganglion here, okay, and then they come together when they form the spinal nerve.
So just for clarification, the motor is front and the sensory comes from the back, the posterior?
Where it enters and exits the cord, yeah. Yeah,
Okay.
motor is coming out the front.
Great.
And sensory is going in the back.
Okay.
And you said where they connect there is a ganglion?
That's where the nerve bodies live for sensation. The sensory nerves live here. They don't live in the cord.
Okay.
Okay? It's the motor nerves that live in the gray matter of the cord.
Okay.
Polio attacks the anterior horns. This is why you get paralyzed with polio. It destroys your spinal cord and anterior horns.
Okay.
It has nothing to do with the brain. You have perfect brain function with polio. It's just you can get paralyzed because of the effect on the anterior horns.
Okay.
And then again, just showing you dura, arachnoid. Underneath the arachnoid in this space is where the cerebrospinal fluid would be. Okay? And then the pia is basically stuck to the cord, just like the brain. This I probably drew a better picture than this to actually get an understanding of what's happening here. But remember, if this is motor, it's coming down the internal capsule, okay, and then it's going through the pons, and it's going to cross over in the medulla, okay, to the other side, run down the lateral spinal thalamic tract, or cortical spinal tract rather, okay, and then it'll synapse on a motor neuron here, and then that is what will send out the actual motor signal to the muscle. So there's two motor neurons. They call it the upper motor neuron and the lower motor neuron. Okay. I think this is getting redundant here too as well. Just again, looking at the cord, just remember that these are the dorsal columns, and then remember the two tracts on the sides that I told you about. Remember that this is the anterior horn, posterior horn. Okay. This is all gray matter. Okay. Sensory coming in, motor going out in red. Okay. Sensory bodies live over here. And, they're called the dorsal root ganglion. Okay. Sometimes it's called the spinal root ganglion as well. That's fine with me either way. just to show you that it's a little bit more complicated than that, okay? This is pretty much PBS here, but you can see how things line up in the cord when you're high up in the cord, and you've got representatives of all the different nerves coming up through the cord. This is where your sacral fine touch and position sense will be, in this dorsal column here, lumbar here, thoracic here, cervical here. They've got this all mapped out. Okay? So as you go on down, the cervical gets bumped out by the thoracic nerves, and then they get bumped out by the lumbar nerves, and then they get bumped out by the sacral nerves. Okay. So, anything else here? Okay. Here's that pain and temperature. Those are the tracks there. Okay. Mostly spinal. Where is it here? There's the spinal point.
I don't see it. So spinal cervical.
There it is. Okay. Yeah. Spinal point track. 5A, right? That's the one we're talking about, pain and temperature. Okay. But you'll see you do have like spinal cerebellar tracts. These are things that are sending up sensory information to your cerebellum, which is how you get your coordination. So they're affecting different things too. So, but the major one going up to the brain is the spinal thalamus. This is an actual picture of the cord. Okay. What they've done is a very large laminectomy. They've cut through the lamina on the vertebrae and taken all the back off, taken the spinal processes and the whole back of all these vertebrae and taken them off. Obviously, this is cadaver. Okay. And then they've split the dura. There's the dura right there. That would be wrapped around, joining the dura over here. So you wouldn't see these roots if the dura was there. Okay. So they split that open, and they've also split open the arachnoid so that you can actually see the subarachnoid space. And you can actually see that there are all these nerves right here. That's the dorsal root, sensory. It's going to come out here. The nerve bodies are going to live in this little ganglion right here, these little lumps. That's where the nerve bodies live. Okay. And so we don't really see the motor in front. Okay. You're just seeing the dorsal roots there. Okay. PBS here, don't worry about any of this nomenclature as far as testing, but I just wanted to show you the circulation system for the cord. Okay. And this right here, this artery that runs up the front part of the cord here, is supplied by roots that come out from the aorta, especially as you're in the thoracic cord. Okay. So anytime you're operating on the heart or the aorta, or it's got an aneurysm, you're trying to fix an aneurysm, you have to be concerned about the circulation that goes back and gets the cord, okay? Because any kind of blockage in those little arteries, if you block off the anterior artery here, you see it gets mostly motor. It gets all the anterior horn cells here. So by mistake, more than one person has woken up from chest surgery and been paralyzed from the chest down. Okay. Because the cord stroked out. Okay, so you got to be real careful when you're fooling around with those arteries in the chest and in the abdomen too. So, so just point of interest. These three terms right here, you do have to know. Are responsible for the conus medullaris, which is the bottom part of the cord, the cone on the bottom. Okay, conus medullaris. Again, the horse's tail, the cauda equina. Okay. That little broom-looking structure down here, all the spinal nerves going down. Okay. And then the little cord that comes down and attaches into the sacrum and anchors the cord, that's called the filum terminale. Filum just meaning hair. Okay.
You said that's the little cord attaches into the sacrum?
Yeah, the cord is attached. Okay. Clinically, that can be a problem sometimes when that doesn't expand the way it should. Okay, filum terminale. I forget the medical term of the condition, but when you're born, your cord is about the same length as your spinal column. Okay, as you grow, the cord gets shorter. That's why it's up at L2 when you're an adult. Okay, so the cord has to pull away from the sacrum. Okay, and it occasionally you get a tight band and it can't pull away, and as you grow, it's pulling on the cord, and it causes neurological problems. Okay?
I think
So
it's-
that has to be fixed.
How do they get spinal fluid from a baby then?
Carefully.
Okay.
Yeah, yeah.
Very carefully,
Yeah,
okay.
you're not really going into an empty space. You know,
Okay.
You're just trying to pop through.
Okay.
You don't have to go too far in a baby. As a matter of fact, you try to go, it's mostly cartilage, they have very little bone there anyway.
Okay.
And so you're just trying to palpate the spinous processes, and you go in the space in between, you can hit the spine pretty easily.
Okay.
Or the cord, pretty easy to get that space. So you stop as soon as you see fluid.
Okay.
You know, and you do it carefully. Okay, so those three names again, they might show up. I just want you to be able to recognize the brachial plexus. You don't have to memorize any of these nerves. This drives medical students mad trying to remember all the roots that go through these bundles, okay? And I never was real good at it. But just recognize what the brachial plexus looks like, and remember that you get the ulnar, median, radial nerve, okay? The axillary nerve, the musculocutaneous nerve here. That's going to get the sensation to the outside of the arm. I think it even gets the deltoid muscle. Okay, the axillary comes in, sensation in the axillary area. And then you have the three nerves that run down the arm. Okay, but they all come from this plexus that arises from different levels along the spinal nerves. Okay, so brachial plexus, that's right in the shoulder here. Just another shot of it, so we don't need to hang there. Lumbar plexus, the important nerve from the lumbar plexus. Okay. Thoracic is real simple because they're just running along the ribs. They're not really joining, they're not forming a plexus. But once you get to the lumbar area, you can see how different levels start to cross over and join make different nerves. Okay. The big one is the femoral nerve. It comes down through that femoral triangle underneath the inguinal ligament. Okay. So if you can remember lumbar plexus, femoral nerve, and anterior, okay, just associate those things in your head, and you'll get any question I ask you. Yeah, and the femoral nerve is anterior.
Because it's the sacral nerve that's the posterior.
You're exactly right. We're going to look at the sacral plexus here in a second. One nerve that's kind of interesting here is the lateral femoral cutaneous nerve of the thigh, right here. It goes right underneath the inguinal ligament, and then it gets its sensation out here. The whole lateral part of your thighs is what it gives you sensation. I must have seen at least 20, 30 people in practice who came in with numbness on the lateral part of their thigh because that nerve is getting pinched off right here. And it can actually be from physical causes like wearing belts too tight. You can cause a paralysis in that nerve. Okay? Occasionally rapid weight gain will cause the nerve to stretch, and you'll get numbness in the thigh. So sometimes pregnant women will complain about it.
Yeah.
Okay. So just as an aside, but remember, lumbar plexus, femoral nerve, anterior thigh. Okay. What do you think it gets, the major muscle group?
The quads?
The quads, quadriceps. Right. Okay. So here's the sacral plexus. It's coming out the front part of the sacrum through those vertebral foramen there. And it's going to run out the back. Here's the sciatic notch, remember?
Yeah.
Okay. And then the ischial spine will be just down below that. Okay. So it's going to run out the ischial notch. The ischial notch. Sciatic notch, sorry. It goes underneath the piriformis muscle, and then it heads down the back of the leg, heading down to the tibial area. Okay. Occasionally you get what looks like disc problems when you have a piriformis inflammation or irritating that sciatic nerve. Okay. It'll give you sensations running down the leg just like a slip disc will when it presses on the nerve up top. Okay. So, and you can test that pretty easily if you get them to, what do you think that muscle does?
Abducts.
It abducts and externally rotates the trochanter.
Okay.
So if you get them to just twist their leg out like that, and that makes the symptoms worse, okay, then it could very possibly be a piriformis syndrome. Okay. This was, I'm not going to be testing necessarily on, you don't have to memorize all this stuff here. You already remember Meissner's corpuscles, though, remember? They're pretty much fine touch. Okay. Pacinian corpuscles were for deep pressure sensation, that sort of thing. And these are the ones that are running up in that dorsal column. So, because that's fine touch, position sense, and then pressure sensing, things like that. Pain and temperature are going up the lateral spinal thalamic tract, right? So, pain and temperature tend to be unmyelinated, so they're slower conducting than these others here, touch and position sense. That's partially why when you step on a tack, you know you've stepped on it, but it doesn't hurt yet. You know, there's a perceptible delay between the time you step on it and you feel the pain. Or you put your hand on a hot burner. You feel the burner, but you don't feel the pain yet. That's pain and temperature. It's a little slower. Okay. Then there are other reflexes going on in the cord that make you pull it away. Okay. You don't often have to think about that. Okay. That's a reflexive reaction. But it's interesting, and why that is, how that developed evolutionary-wise, I don't know why that would be an advantage, or maybe it's just something that, it's just the way it is, okay? But, okay. Sympathetic and parasympathetic system. We've talked a little bit about fight-or-flight kind of situations. Now we're just going to set it up here. Almost the parasympathetic sensations that you get around the face and neck, most of those are coming through various cranial nerves, okay, and you don't have to remember which ones do that, okay. But the vagus nerve is the big one, cranial nerve 10, remember, that has all the parasympathetic activity for most of the rest of the body, okay. Everything from your lungs and your heart, your digestive system, your liver, you know, the kidneys, and just about everything. And that comes out of the brainstem. So, and then there's no more parasympathetic activity coming out of the cord until you get down to a little sacral plexus down here. And this is going to get, it gets the bladder, but it also gets the uterus and the prostate and the ovaries and that sort of thing. So the parasympathetic fibers are coming out of the sacral plexus. So they call it a craniosacral outflow is what they call it, okay? When you look at the fight or flight system, the sympathetic system, okay, that comes out of the thoracolumbar region here. It comes out of the cord. These are motor. In other words, these are motor neurons that are sending signals to the stomach to inhibit its contraction, or sending signals to the heart to accelerate its speed. You know, so these are active neurons. Those bodies actually live in the anterior thorn as well, okay, along with your other motor nerves for your skeletal muscles. And then there's a second nerve out here somewhere, either in this area right here. It's almost like a second nervous system, okay, or a second spinal cord. And I'll show you a picture of it here in a second. It can have a synapse here and then send out a signal to your lung. Or it can synapse in little plexuses around the body. The solar plexus is a fairly large one. It's right up underneath the breastbone. Everybody's probably heard of your solar plexus, but you didn't know what it was. Well, it's a bundle of sympathetic nerves. Okay? And the only one that doesn't have a synapse or two nerves in the system, okay? So in other words, the nerve body will be here, it will come out here, it will synapse here, and then it will send a message to the stomach, okay? The only thing that doesn't do that is the signals that come out and go to the adrenal gland. The adrenal gland itself acts like that second nerve, dumping adrenaline into your blood system. Okay, so it's making all that adrenaline just like the nerves are.
So the adrenal gland is the one that doesn't synapse.
It has no synapse. One nerve goes from the spine to the adrenal gland.
To the adrenal gland.
Okay, everything else is a set of two nerves. Most things in the body have both sympathetic and parasympathetic innervation, just like your iris. Sympathetic dilates it, parasympathetic constricts it. Okay. A couple of things that don't have any parasympathetic innervation that I'm aware of, unless they found some recently, okay, are your sweat glands and the erector pili muscles in your along the hair follicle. Okay. So that's why when you hear that bang or that lion roar, your hair stands up, that's a sympathetic response. Okay. There's no parasympathetic innervation of the hair on your skin. And just tell you a little interesting medical story here. There's a classic medical condition called Horner syndrome. It's when you have injury or tumors in the neck or the upper part of the lung, and they cut off the top part of this sympathetic chain here. Okay, they destroy this, so you're no longer getting innervation from the cord up to your eye or to your skin to sweat. Okay, so more than one guy has walked into the doctor saying, "It's weird. I'm mowing the yard and the right side of my face is not sweating." You're looking for lung tumors most of the time. Most of the time. Okay. He may not even notice that his pupils are a little different size, but sometimes they'll complain of a little blurred vision because of that. Okay. But you lose sweating on the side of the face. That's the superior sympathetic ganglion right here that's been knocked out. Okay. And the most common cause I know of is lung tumor in the apex of the lung, okay, growing into that. It's an interesting thing though. Now that they're doing brachial plexus blocks, okay, for shoulder surgery and arm and elbow surgery, things like that, it's great because they do what's called an interscalene block. They go between the scalenes with the needle, inject the anesthetic in there, and it blocks the whole brachial plexus for about 24 hours. So people don't even need pain medication when they come out of surgery. Okay, my wife just had this done a few months back because she had a bone spur in her shoulder. So they come home after a couple hours and just that's fine, and they just start taking the pain pills the next day.
Yep.
Okay? When the feeling comes back. But what can happen though when you do a scalene block is that you can what's called an iatrogenic effect, a doctor made. Okay. You can block off the sympathetic ganglion here with the anesthetic and get an artificial Horner syndrome. Okay, so they warn you, and he was really surprised that I guess he didn't know I was a physician. The anesthesiologist was coming in to talk to my wife. And he said, well, when you wake up, you might have a little problem with your pupil constricting. She said, and you might have a little problem sweating over the next day or so. And I said, that sounds like an artificial Horner syndrome. He goes, what? He said, yeah, how'd you know that?
Just guessed.
Just guessed. I read it somewhere.
It just came to me from nowhere.
I read it somewhere. I learned that in high school. Okay. And as we talked about before, you can almost guess what these systems are going to do. Just think about what you want to be happening when you're in a fight. Okay? You don't want to be wasting energy with your stomach churning and digesting food and your intestines working and your kidney blood flow. You don't want to be putting blood flow through your fat and your skin. So the sympathetic system tries to shunt everything to the muscles, blood flow to the muscles, and that's what it's mainly concerned about getting going. Okay, so everything else is parasympathetic. Okay, the opposite of what you would think for fight and flight is parasympathetic. Okay, so rest and digest. This is what the sympathetic chain actually looks like on the side of the vertebrae. Okay. Most people don't even know it's there. They've never heard of it. Okay. So here's your spinal cord. Okay. And those little nerves, the motor nerves for the sympathetic system, are going to come out the motor root, go past the ganglion, through the spinal nerve, and then they're going to kind of twist around and go up or down this chain right here. Okay. That's called the sympathetic chain. And it's something like this that goes on up into the neck. And that's what we were just talking about paralyzing. These nerves right up in here as you go up into the neck. Okay. So that's called the sympathetic chain right there. And they come together to form other kind of plexuses. That could be the solar plexus right there. Okay. That could be the second nerve, where the second nerve bodies are. Again, just more pictures. This is a little better if you want a little more detailed information about what the systems do. Again, the sacral parasympathetic. Vagus gets just about everything, but the sacral nerves will be getting the sexual organs, uterus, ovaries, bladder, and that sort of thing. questions on that? I know it's kind of hard to wrap your head around, so you understand it all the first time. Just don't know what to ask.
Yeah, okay, so the parasympathetic and the sympathetic, they control all the organs. So like there's a parasympathetic reaction and a sympathetic reaction.
It's like your unconscious nervous system, okay? And so if I'm afraid, somebody jumps out behind a tree, my heart starts racing.
Right.
That's sympathetic, okay? My bronchioles in my lungs will dilate. Basically, the smooth muscle will relax, and so that lets the airways open up, get more air in. Same with the blood flow. The smooth muscles and the little arterioles relax, more blood flow to the lungs, more blood flow to the muscles. And
Does that cause the dump of the adrenaline as well?
Yeah, oh yeah, it's all part of it. That's it. You know, that's like an added-on amplifier. Okay, and that doesn't take very long for that adrenaline level to get pretty high. But it's amazing how fast the system is. I mean, just think about when boom, when you get scared, how fast the hair on your skin will raise up, and how fast those chills come, that tingly feeling from all the adrenaline. It's a quick system.
And the sympathetic then takes over when our body has
You
to.
mean parasympathetic.
Okay, the fight or flight.
Oh, that's sympathetic.
Okay,
I thought you were-
that takes over when
Oh, yeah.
we have to like preserve our life, let's
Exactly,
say.
exactly.
But when we're just in a homeostatic kind of thing, that's parasympathetic, just kind of doing
Yeah,
its normal.
but it's
everyday
not
thing.
like it's lazy.
Okay.
Because when you eat something,
Right.
the parasympathetic system has to fire up.
Okay.
Okay, so it's not like it's just resting.
Right.
Okay, that's why I say rest and digest,
that's
because
why
that's
you
an
said
active
that.
process.
Right.
Okay.
That's an active process.
Okay.
So it's stimulating the stomach to contract, to secrete digestive juices. It's stimulating the liver and the intestines and the bile and all sorts of things. So it's not just a resting system. It's active when it needs to be.
When it needs to be.
Okay, but the fight or flight is when you don't want to be doing any of that
Right.
when you're fighting.
Right.
And so, like I said, you can almost guess what each system will do with any particular organ. Okay, so, and it's a little more confusing because it's backwards sometimes. Because this sympathetic system, it will cause the arterioles in your muscle to loosen up, to relax, so you get more blood flow through your muscles.
Right.
But in your fat and in your skin, the same system causes those smooth muscles to constrict. So you don't get blood flow through your skin and fat. So there are two types of receptors on those blood vessels, and the adrenergic receptors in your skin and fat will cause constriction, but the adrenergic receptors in your muscles will cause dilation. And that's why you want to block the adrenergic receptors in your skin and fat if you want to lower your blood pressure. Okay? So, because they'll constrict it. So if you want it to open up and lower the blood pressure in the whole body, that's why you give certain drugs like clonidine to block the alpha adrenergic receptors. Okay, they call them alpha receptors and beta receptors. People have heard about beta agonists for their inhalers for asthma. Okay, those are beta receptors in the lung. So when you give a beta agonist, you're giving a sympathetic drug that will relax the muscles and let the lung open up to cure the asthma attack. Okay. But there are several different kinds of beta receptors, and the ones in the lung, though, the beta-2 agonist, okay, for dilation. So if you actually, if you want to cause an asthma attack, you give a parasympathetic drug, because that would clamp everything down. Okay. So there are, like I said, there are lots of blood pressure agents that are working on these systems. Okay, they're either blocking the ion pores in the system, or they're mimicking the transmitter, like they're mimicking the structure of adrenaline, okay, or norepinephrine to make the system fire more. Okay, but and then we talked about all those other things that can happen, calcium channel blockers and all sorts of things. So now you're starting to kind of understand how a lot of different drugs work and the rationale behind them and why we're using them. So, that's for the other of you who haven't seen this, you'll get this tonight in lab. We'll go over the ear, okay? Let me fly back through and let's cover things that we might want to go over. We've done all this today. How are we doing on the cranial nerves? Okay. Let's see how fast you are. Okay. Raise my shoulders.
Not fast enough.
Raise my shoulder, turn my head. Accessory, spinal accessory, yeah, number 11. Okay. What's number 12? No cheat, no cheat. Let's see if you know them now. I haven't had time. Okay. Let me do them real quick again. Okay, olfactory and optic, pretty easy. Just for a sense of smell and vision. Number 3, another O, okay, oculomotor, gets all the muscles around the eye except for the lateral rectus and the superior oblique. Okay. Superior oblique, that's the trochlear nerve. Number 4, the lateral rectus is the abducens nerve. Number 6. Okay. So if I got a 6th nerve out, my right eye can't look out. Okay. But if I tried to look to the right, my left eye would still be working because it's oculomotor on the medial rectus. So if I have an abducent injury, my right eye won't look out, but my left eye will cross over. So it's all I get a weird kind of cross out. It go like that. Okay. And
He says all of that around the eye except now.
He
says all of that around the eye except for 2.
except for the superior oblique and the lateral rectum. Okay. That's the abducens. So looking up requires what? Olfactory? Oculomotor. Looking up, that gets the superior rectus, right? So that's, looking up is superior rectus and oculomotor. What about, I get sinus pain. What nerve is that? Trigeminal, right, is sensory to all the face, the teeth, the sinuses, the eyes, everything around the face is sensory. That's trigeminal, okay, in 3 different branches. Motor trigeminal does what? Chewing, mastication, right. What gets the muscles facial expression? Facial nerve, that's easy. Right. That's the Bell's palsy nerve. So when you get a Bell's palsy, your face will droop, but the sensation is fine because that's trigeminal. Okay. A lot of people will come in saying, my face is numb. Well, no, it's not. It's just, it's weak. Okay, the sensation is fine. Okay. And then, let's say 9. Sounds like you had that right on the Glossopharyngeal, swallowing, sensation to the throat, gag reflex. Let's associate those things together. Okay. Hypoglossal, underneath the tongue, stick out the tongue, move it side to side. That's 12. That's hypoglossal. Okay. Vagus is everything we've been talking about today with the parasympathetic system, basically. Okay. 8 is easy, nice hearing and balance. Okay. We'll go over those tonight with the rest of the group. So, okay. These are the only 2 you should be able to remember or pick out on a picture: the olfactory bulb and tract, the optic nerve, the optic chiasm. Okay. Know what Broca's aphasia is, or Broca's area is. Remember, it's the motor for speech. Okay. And then Wernicke's is the misunderstanding of grammar and language. So it's a sensory issue, essentially. Okay. And just remember where the sensory and motor strips are. The central, postcentral gyrus. Auditory region is in temporal lobe here, and visual is in occipital. Okay. Associate those together. You should have a basic idea of where the fluid is forming and where it's going, okay, to be able to follow the fluid track.
I have a question for you on that.
Yep.
The foramen meningi goes down to the spinal column. Foramen Luschka goes up and around the...
Not really. They're about the same level, but foramen meningi is in the middle.
In the middle.
The foramen Luschka is on either side. There are 2 of them. They're lateral.
Okay.
So they're just holes. They're just holes where the fluid is going to come out and flow out through all this.
And that's all in the 4th ventricle.
Close to it,
Close
right.
to the 4th ventricle.
It's almost connected to it, right.
So the fluid that goes through the foramen of Luschka, that's not what goes up and around the
Well, it could, but they all could.
They all do.
They all could. It's just flowing out.
So Tudor on Sunday told us the Lushka up and around and the Meningi went down.
Not necessarily.
Okay.
Not necessarily. Well, I'll check, but
No.
as far as I know, it's just dumping it into that region.
Okay.
Naphthalina, section. You should be able to recognize the corpus callosum, septum pellucidum, the fornix, the caudate, the putamen, the globus pallidus, the internal capsule, the white matter going down. Okay. Thalamus on either side of the third ventricle. Okay. I guess insula. Okay. Temporal lobe, and either parietal or frontal. I wouldn't ask you that because it's hard to tell right there. Same sort of thing there. Here's a transverse section. Again, corpus callosum, lateral ventricles, septum pellucidum, fornix, head of the caudate on either side, putamen, globus pallidus, internal capsule, thalamus here, okay. And corpora quadrigemina right here, okay. Superior colliculus, inferior colliculus, cerebellum, again, insula, temporal lobe, frontal lobe, that would be obvious. Okay. Let's just get this one here. You're going to see a picture very similar to this. Okay, and I'm going to have lines drawn. What's that right there?
The pineal gland.
Right, because it's listed. Let's travel on back here. See if there's anything on the circulation. The circle of Willis, the basilar artery, and the two vertebral arteries is the one. 3 random ones I'm asking you to remember. It's pretty easy to remember the middle cerebral and the anterior cerebral too as well, but I'll make it a little less stressful. This is the pathology is all PBS or extra credit. The Fowlkes is not. Okay, Fowlkes is important. Fowlkes cerebri and the tentorium cerebelli. Okay. And again, just remember, have an idea in your head about how these layers come about. The meninges, the dura, the arachnoid, and the pia. Okay. And the cerebrospinal fluid is in the subarachnoid space. Okay.
But it's generated in the septum pellucidum, right? Or near there?
Well, septum pellucidum are axons forming a membrane. It's
Okay.
generated in the choroid plexus.
Which is right in that same little...
Yeah, it's a little veiny looking thing. It's in the
Okay.
ventricle and it actually comes into the third ventricle as well. And I think there's a little bit down in the fourth ventricle.
Yeah, I've been noticing that.
Okay.
It's mostly produced up in the third ventricle? Or is it produced in all of those choroid
All of
plexus?
those.
It is.
Yeah, it wraps around from the lateral
Yeah.
ventricle and there's some in the third. Okay. So it's those ependymal cells, remember, we're doing that. That's the glial cells that are forming the choroid plexus. It's the ependymal cells. Remember the 4 different types of cells we talked about?
Yes.
The lobes of the brain. Did we cover this?
Yeah.
Again, that's all PBS when it comes to pathology. Hirschsprung's is PBS. Enteric nervous system, we talked a little bit about
Yeah.
our brain and our gut.
Yep.
Let's talk about just reflexes here real quickly. And then, whatever time left, we'll talk about the neurotransmitters. But, I'm not stressing the chemistry part. Okay. Monosynaptic reflex arc. This is a standard term. This is what you get when you get the knee reflex. All muscles all skeletal muscles have these little spindle bodies in them. They exist in the muscle. They're inside the muscle. Here's a picture of them. They're little nerve organs. They're mechanoreceptors. In other words, stretch is what opens the pore and depolarizes the cell that sends the message. Okay? So you don't need a chemical receptor or a voltage or anything. It's actual physical stress that pulls the pore open, and that depolarizes the cell. Okay? And so go back here. So that's going to fire. It's a sensory organ, so it's going to have a nerve body here in the spinal ganglia, and then it's going to go in here and have a synapse with a motor neuron, and that motor neuron is going to go out the ventral root and send a message back to the muscle to contract. Okay? That's why they call it a monosynaptic reflex arc, because there's one synapse in there. It doesn't even have to go to the brain. Okay? So when you tap on somebody's knee, if their spinal nerve is intact, okay, you're going to get a normal reflex. Okay? If somebody has there are some inhibitory nerves coming down from the brain, from like the cerebellum and the basal ganglia and that sort of thing, they will actually, if you cut those off, like break your back, your reflexes actually get stronger, because now that reflex is not inhibited anymore, and people that have had those kind of lesions are real jumpy. You know, you just touch them, they're really jumpy, and they call that's what's called upper motor neuron problems. Okay, the upper motor neurons have been cut off, and inhibitory. Matter of fact, I think I even brought my little reflex hammer today. All muscles have that kind of reflex. Everybody's familiar with the knees and that sort of thing. You can, if you want to confuse the brain and make that a little stronger, you get the patient to sit down. And I'm not exactly. Stop moving. So I'm getting a pretty good jump there. I can make that stronger if I confuse the brain with some activity by getting the patient to pull their arms like this, and then their reflexes will get stronger, because you're blocking some of the inhibitory neurons. But all muscles, like I say, have that. If I just relax my arm, I can hit the extensor digitorum muscle up here. If I pick the right spot, I can make my fingers jump. Okay? So now I'm getting the extensor carpi radialis. I'm causing my hand to pull over that way. See that? But now that's the extensor digitorum back here. Boom, boom. Okay. So all muscles have those reflexes. Your biceps, your triceps, the Achilles tendon. Okay. You can test that just by taking the patient's foot. The foot's like this. You just take your hand and you just jerk your foot up, and that stretches the tendon. And you should get 1 or 2 beats of reflex. Okay? If you have those upper motor neuron problems where the inhibition is not there, you'll get what's called clonus, where you pull on your foot and it just keeps doing this. That's called clonus. Okay? It's common in strokes and that sort of thing. Okay, so monosynaptic reflex arc. That's the stretch reflex right there. Okay? And then next is the Golgi tendon reflex that you want to be familiar with. Just know what it is, basically. But you'll see this is a little bit more involved. It's a structure, the receptor is in the tendon, or very close to it here, okay? And so it's measuring the stretch on the whole muscle, not just the tension in that area, like the other one is, okay? So if I've got, it's like a meter here on the tendon that's measuring how much stress is being put on that muscle. And when there's enough stress being put on that tendon, pulling and pulling and pulling, it will fire. It's a mechanical receptor too. So when the stretch will open up the ion pullers, okay, it depolarizes, it sends a message back through the sensory arm here to an inhibiting interneuron, which will then stop the motor from contracting. Okay? So this is a protective reflex so that you can't stretch the muscle, you can't strain it enough to tear it. Okay? And most of the time when you're, well, I think I mentioned something on the next slide here. Yeah, here. This is called the Golgi tendon reflex, or the give-way reflex. Okay? It's just, if you get so much strain on the muscle, it just gives way sometimes. Okay? That is protecting you. And most people think that when you're constricting your muscle, your biceps, as hard as you can, roughly 1/3 of the fibers in the muscle will be firing at once. Okay? It's not all of them. Okay? If you fired all of them, the force generated by 95% contraction is sufficient to damage the body. In other words, you get those avulsion fractures. Okay? So that's why if you took electrical probes and got all those fibers to fire, you'd probably pull the tendon right off the bone. Okay? So the Golgi is a protective reflex. It doesn't allow you to do that.
So like, what about like arm wrestling? Let's say two people going at arm wrestling. Would that, the body then protect itself from
If it had to,
if it injuring
yeah,
the muscle?
they train themselves to do all that. But yeah, I guess, occasionally one guy's going to go, ah, it just goes.
Yeah.
But sometimes you don't know if it's give up
Give up.
or give way. So it's hard to tell.
Yeah.
But but I think you get the idea of how it works. Okay. So was there anything else here? This was just to sort of lay out the different kinds of sensory receptors that we do have. We've already talked about the mechanoreceptors for the stretching ones that we talked. Hearing and balance, those are mechanoreceptors. Tonight we'll talk about, if you haven't done it already, those hair cells in the vestibular system and in your hearing. When they move, that's what opens the pores. Okay? So, and especially in hearing, they've got little trap doors. The hair cells will move, but they're connected to each other, so that when one goes this way, it pulls the door open on the pore, and that's what depolarizes the cell. Okay, so the ions rush in as the door gets pulled open. So they're connected and rotating together like that. So they're mechanoreceptors. Photoreceptors, obviously, are eyes, light. Chemoreceptors, like smell and taste. These rely on molecules getting in those proteins and causing a change in membrane, okay, protein. Thermoreceptors, they basically fire just from changes in temperature. Okay? So when the protein gets colder, it's closed, but when it gets colder, it shrinks and fires. Okay? That's what opens the pore. And your hot receptors, just the opposite. When you heat them up, they open up, and that's how you depolarize those neurons. Okay? So they're simple, just that their shape is related to the temperature. Okay? And they're two different receptors. It's not one nerve that senses cold and hot. They're two different receptors, so you can actually be born without one set or both. Okay? And then electroreceptors, which we don't have. These are things like a lot of fish have it, sharks, rays, the electric eel has it. There are some animals that have it, like the platypus. They have electroreceptors.